Shown you this diagram once already. Gosh, it's on a second time. Perhaps it's important. On to the next one. This is the sympathetic outflow of the cat. The diagram is after a diagram from Tony King in 1984, which is in King's anatomy book. The sympathetic outflow is a thoracolumbar outflow. Here it is in the cat, going from T1 to L3. But remember that it's L5 in the dog and different in different species. I'm not going to get dull and quote you a whole table of different sympathetic outflows in different species. Just remember that it's different. The reason that I remember that it's more caudal in the dog is because, as an anaesthetist, you tend to do quite a lot of epidural anaesthetics in the dog. And under some circumstances, the local anaesthesia travels more cranially in the spinal cord and anaesthetises nerve outflows more cranially as it goes. And occasionally in the dog, it gets to beyond L5, to beyond the end of the sympathetic outflow, and these animals lose sympathetic tone in the caudal part of their body. Their vascular tone goes down, they get a vasodilatation in the caudal part of their body, and all the blood that you would be far more happy perfusing, the coronary perfusion and the cerebral perfusion and the renal perfusion and all those things, goes to perfuse the left toenail, which is not that important when the dog's anaesthetised. But it does do interesting things to the dog's blood pressure, much more common in the dog than in the cat, because the outflow is more caudal in the dog than the cat, and so the local anaesthetic is more likely to reach it. How does a sympathetic outflow from the thoracolumbar region get to the dog's left toenail, to the whole of the somatic parts of the body? The outflow comes out from the spinal cord into the sympathetic chains, which are parallel chains, one on either side of the animal. And within those chains, these presynaptic fibres travel to the segment of the body where they will finally innervate a tissue, which might be somewhere down here in the lumbar region, might be in the sacral region or the coccygeal region, wherever it gets to. It then has a synapse with its postsynaptic nerve cell body. The postsynaptic nerve then goes back into the spinal column, where those fibres hitch a ride on the somatic nerves and travel with the somatic nerves down to the somatic areas of the body. So it's a kind of a out, down, in, out system. It's a bit complicated, but once you work out that it's a way of getting an outflow that is just a segmental outflow to different parts of the body, it kind of makes a bit more sense. Preganglionic fibres are generally short. They generally stay in the sympathetic trunk, except for the caudal and cranial mesenteric ganglia, which I've simplified there into two ganglia, and also the adrenal medulla, which has very short postsynaptic neurons, because those postsynaptic neurons in the adrenal medulla are endocrine. One of the big concepts of neurophysiology that I want to mention, probably for most of the last 5 minutes, is that synapses equal processing of information. That's what they're for. If you want to get information from this side of the room to that side of the room using a nervous system, the fastest way to do it is to have a single cell going all the way across and have it myelinated and have the thing go straight across by saltatory conduction, 120 meters a second, gone, sorted. But if you want to process the information and decide what it means on the way, then the best way to do that is with synapses, because synapses alter the information and they process the information. They think, in inverted commas. And so when we look at a sympathetic ganglion, we don't see one preganglionic cell synapsing with one postganglionic cell with one postganglionic cell fibre. That's how I've illustrated them to show you how they fit together, but it isn't that one-to-one relationship. We've got all these tangles of presynaptic axons and postsynaptic dendritic tracts, all wrapping into each other, all processing the information. And so many presynaptic cells are affecting whether or not each individual postsynaptic cell reaches its action potential and so sends a synapse along the way. So it's processing the information. And the concept that I want to talk about is a concept of hierarchical processing. There's a great danger in the way that many people are taught schoolboy science, as it were, to think of information going all the way up to the brain in the spinal cord, the brain thinking about it and being really clever, and the brain sending motor information all the way back down to the tissues. Yeah? But it doesn't happen like that. The processing happens at every level. If you want an example of hierarchical processing, then any business that's successful is probably a good one to look at. In the sense that people that work for a business are taught to deal with information at a low level when possible, but pass the information up to a higher level if it's more important than they feel able to deal with. Okay? You go to McDonald's and you order your hamburger and you get your burger back to the table and you open it and it's a bit cold. It's been there for 10 minutes and you think, well, that's not very nice, is it? So you take it back and you go to the person on the counter and you say, this was a bit cold, don't like it, what are you going to do about it? And they say, sir, I'll get you a new one, no problem. Here's a nice steamy fresh one, take it away, be happy and eat at McDonald's again. You go away, you eat your nice, well, your warm burger anyway, everybody's happy, possibly apart from your gastrointestinal tract, but everybody's happy and the world carries on. Now let's imagine a slightly different scenario. You get your burger, you go to your table, you sit down, you open it, and there's a dead mouse in it. Okay? You take it back to the counter, you show it to the person on the counter, and they say, oh, I'm not paid enough to deal with that. And they go and see their manager. And their manager says, oh, I'm not paid enough to deal with that. And it goes to head office. And head office says, thank you so much for bringing this to our attention. Here's $100 of McDonald's vouchers, and please don't tell public health about it. Okay? The information was more important for the function of the McDonald's enterprise as a whole than just this one little person on the counter felt able to deal with. And so it's passed up the way. And that's how information works in the central nervous system. Information that comes up to the spinal cord that can be dealt with at a spinal level, a reflex is appropriate, or a slight change in vascular tone is appropriate, is dealt with at that level and often doesn't make it any further up. You put your foot into a steamy hot bath and the whole of your central nervous system knows about it because, oh, that's too hot, out we come. It's got bigger consequences. It requires a bigger response than just a local response, and so it's passed up. If your central nervous system worked in the way that's suggested by many school textbooks, where all the information went up to the top and was processed and all the information went down again, then your spinal cord would need to be as thick as your thigh. And your brain would need to be as big as a telephone box. And the cardiovascular and locomotor consequences of trying to get around with a system like that would be difficult. So we have a system which we call hierarchical processing, whereby information is dealt with at the lowest possible level. And that's what's going on in these sympathetic ganglia. There is, in a very small sense, thinking going on in these ganglia. There's information processing. There are decisions being made about what to do with this information and how to change this sensory input into an appropriate motor output. And that's going on throughout the whole of the nervous system, the whole of the time. And what we are conscious of and aware of is a very tiny amount of that. Okay, remember the cat from yesterday. The cat with the clinical syndrome that we were able to describe. This is known as Horner's syndrome. Okay? It's an abnormality seen in the eye. It involves drooping of the eyelid, constriction of the pupil, proptosis of the third eyelid, and enophthalmos. Who can have a guess about which part of the nervous system is involved in this syndrome? Because if it wasn't something to do with the nervous system, I wouldn't be telling you about it. Any offers? Parasympathetic? Okay. Parasympathetic stimulation could give you most of those things, couldn't it? Could constrict the pupil, could cause the third eyelid to come across a little bit. The thing that parasympathetic stimulation probably wouldn't do is that drooping of the upper eyelid, okay? But in saying that parasympathetic stimulation is doing that, you've kind of got the right answer, but you're on the flip side of the right answer. It's a reduction in sympathetic activity, not an increase in parasympathetic activity, okay? And it's due to damage to the sympathetic innervation of the eye. So, where does the sympathetic innervation of the eye arise in the spinal cord? T1 down to L somewhere? Yeah, okay. So, the cranial part of the body is probably coming from T1, yeah? How does that sympathetic innervation get from T1 up to the eye? Yep, sympathetic nerve trunk. Where does that travel? Travels up the thoracic cavity to the ganglion that I call the stellate ganglion because I'm a dinosaur, but you probably call it the caudal cervical ganglion, I can't remember. Yeah, okay. And then it goes up the neck, yeah? Where does it travel when it goes up the neck? It travels in a group with some very important structures. Yep, travels with the vagus. Good. It's the vagus sympathetic trunk. Yep, that's right. It's the sympathetic part of the vagus sympathetic trunk, and it travels with one other important structure. Yeah, the carotid artery. That's right. So the carotid artery, the internal jugular vein, although that's small in our animals usually, and the vagus and the sympathetic chain all travel together in that one structure. Speaking as an anaesthetist, how much fun is it when a surgeon hits that with something sharp? Ooh, all sorts of fun. So worth knowing about it, worth knowing where it is. Let's talk about how Horner's syndrome can develop. This is a diagram of the sympathetic innervation of the eye. And you can see that it's coming out of T1 to T3. This is the preganglionic neuron. This is the ganglion with the synapse to the postganglionic neuron. This is the middle ear, and the structure passes close to the chamber of the middle ear, and then it travels up to the eye. So there we go, cranial cervical ganglion and middle ear cavity. We know from Horner's syndrome that that pathway is damaged at some point, but we can't tell where it's damaged. There is, however, a cunning way for us to decide which part of the pathway is damaged. And it's both cunning clinically, but useful in a physiological sense because it's going to illustrate for us another physiological principle that we will meet again next semester, but that I want to mention briefly now. If we put 10% phenylephrine into the eye as eye drops, phenylephrine is an alpha-1 agonist. What is an alpha-1 agonist going to do in the eye? Ooh, we haven't done pharmacology yet. But because you've all been studious and you know where the alpha-1 receptors are and which part of the autonomic nervous system they're attached to, you should be able to work it out. Yeah, dilation. It's going to cause dilation of the pupil. And in a normal animal, topical 10% phenylephrine will cause dilation of the pupil in about 45 or 60 minutes. So you drop it into the eye, the animal goes away, an hour later the pupil's dilated. And ophthalmic surgeons use it quite regularly prior to cataract surgery, so they've got a nice big pupil so that they can get into the caudal chamber of the eye. We've got 3 neurons in the pathway. An upper motor neuron, in inverted commas, because it's not really an upper motor neuron, it's an upper autonomic neuron. A preganglionic neuron, and a postganglionic neuron. And what we find is that if we've got first order Horner's syndrome, i.e. damage to this first order neuron, the first in the pathway of 3, we get dilation of the pupil in 60 to 90 minutes. Broadly speaking, it's normal. But we know that there's a lesion there because it's Horner's syndrome. And that typically would be caused by central nervous system disease, central nervous system neoplasia, meningitis, something going on within the central nervous system. The second order neuron If that's damaged, typically a Staffordshire Bull Terrier or a Bulldog that's been on a choker chain and the owner's been going, stand back, because you know how they love to pull and damage their neck, you will get dilation of the pupil in about 30 to 45 minutes maybe. And if we've got third order damage to the third order neuron, we'll get dilation in about 20 minutes. So what we're seeing here is that the time taken to cause dilation of the pupil is more abnormal the closer the lesion gets to the effector site. And that is something that we see in neurophysiology a lot of the time, certainly in clinical neurology. The closer a lesion or an area of damage is to the site where we see the abnormality, the more profound the abnormality, but also the more localized. So that, for example, if you've got first order Horner's syndrome, you will probably see some other central nervous system signs as well as the Horner's syndrome. If you've got third order Horner's syndrome, you might well see some other signs of middle ear disease. The nearer we are to the effector site, the more specific is the damage. The more abnormal and the more localized. And we'll meet that again when we get to the motor system in the second semester.